Hello, everyone. My name is Dr. Madhura, and I'm here today to talk to you all about what we offer for our Part 2 MRCOG journey. I hope I'm audible and all of my slides are visible to you guys. So, today we're just going to talk about what is MRCOG Part 2, how can you prepare for it, and also I will be going through a bit about the fetal growth restriction guideline, and it's a big guideline, so I'll be just going over the main points with you guys. And before we begin, first of all, congratulations for completing your part one. It's the first stepping stone, and we have two more stepping stones to go before you get the MRC or before you're admitted as a member of the Royal College. Um, uh, One thing that we need to understand is that with these exams, it's a long journey. It takes a couple of years to complete all three. But what is important is that small efforts need to be taken each day. So this exam is mainly for trainees in the United Kingdom, but people who have trained outside can also take this exam and become members of the Royal College. Uh, for for people who are not trained in the country and who've trained outside, for them we have the same with me. I've been trained outside the United Kingdom as well, but we have our knowledge. But what we need to understand is that here they follow certain what do you say, certain protocols and certain guidelines, and this is the essence of part two exam. Basically, this is where we have the background knowledge, but we need to know how things are done here. And for that, we need to take small efforts, and day in and day out, you need to read and practice the the questions. It can be a bit difficult. I wouldn't say difficult. It would be a little different from what we do in our respective, countries, but it is definitely something worthwhile learning, because I always tell everyone this, that become a better clinician. Whether you work in the UK, whether you continue working in your home country, you just tend to become a better clinician and a communicator after giving all three exams. Uh,
Mommy, can you be
one of
my
the main
mommy?
important
हाँ वो
things
मम्मी मम्मी
One of the main important things is to set
हाँ
clear goals, take
तो
breaks, reward yourself, stay positive, and surround yourself with motivation. That basically means is that it's we need to know what we need to achieve. That's the first thing. If you know you're setting the exam in 3 months, you need to know you need to study in 3 months. If you're taking a while, given your workload, given how you're doing every day, you just need to know yourself. Your goal will be your own personal goal, and you cannot compare your goal to someone else's, because we don't know what stage in their life is. Second is we need to take breaks. In the form that it can be a bit relentless to study every day, but that's fine. You need to incorporate small breaks in your schedule. Always stay positive, and it doesn't harm to have someone with you along this journey. Obviously, we as a team are there, but if you have a study partner, if you have someone studying with you, that's a good, it's just a plus point as well. Now, the most common concerns that people who are studying for the part two have is that it's so vast. Okay, you have so many guidelines. You have the green top guidelines. You have the nice guidelines. You have the reviews from the obstetrician and gynecologist. That's the TOG. So, what is the study material? So, it's a big vast ocean of study material. How do we manage the content? You can't really remember everything. So you need to study smart. That's one thing. What's in paper one and paper two, we will be talking about that. How will I manage with my job, with my family? All of this is again a personal question as to how you find yourself, if you're able to incorporate the study time along with your other commitments. EMQs are basically extended matching questions. These are something different, and maybe we aren't very used to solving such questions, but they form a major chunk of this exam, and this is something that needs practice from the beginning. How much do we have to go in the detail is that, yes, we will have to read a bit. All of us have the basic knowledge of our subject. We just have to delve a little into it. Um, how many percentage? I'm sorry. Uh, so basically the scoring system is different. Every exam has a different passing percent, and if you get above that, then you clear. But it can be 65 for one. I think this year it was 65 for the last one, and you just have to clear that passing percent. It's not 50% like normal exams. It's different. Will I be able to do it? Yes, you can. You just have to put your head in the game and okay, if I have to achieve this, I have to work towards this. How much time is required? Again, it's on the personal commitments that you have, how much time you can give to studying every day, and also how much time you feel you can give for practicing. Another thing is that you never really feel ready to give this exam because you feel you're unprepared. But I feel you should just give it when you feel you're best prepared. Many people, even in the United Kingdom and in outside, have repeated the exam. Why? Because it is a difficult exam. But if you do it right, if you study smart, if your head is in the game, you follow your own plan, you will be able to clear it. There are a lot of people who clear it in the first go as well. Okay, so please don't be disheartened. And even if we have someone who's given it in the past and is again wanting to give it again, it's completely okay. I've had consultants tell me that they've given it 4 times or 5 times because it is a difficult exam. But now that we have someone to, help us out to tell you all how to read or tell you all how to solve, and that becomes easier. It is difficult, it is expensive. There are multiple resources that you have. Time management is important. I wouldn't say spouse here, I'd say family, because it is important to have needs and expectations. Because it can be anyone. It's because if you're a father, you're a mother, you have to have some balance with the whole family thing. And I think a lot of people find this difficult as well. Workload, yes. Home duties, yes. But what is important is that you need to have proper information as to what needs to be read, what needs to be solved, what needs to be revised. And that's why we're here to help you out. Um, one thing is important is that you have to have a positive mindset. It's very easy to get demotivated. It's very easy to feel that you're not going to make it, you're not going to be able to do it. But I think you should just keep your blinders on like a horse and just look at the goal and stay positive. Baby steps are important, and important is to keep on moving forward. Now, the exam structure is, it's first of all, it's a computer-based test. That means you have to give it on a computer. It's just like a part one. But here, a part one only had single best answers. That means you had 4 or 5 options and you have to just pick one. On the other hand, this exam has 40% single best answers and 60% extended matching questions. So, what are extended matching questions? Extended matching questions, I think in the end there's an example of what they are. It's basically there's a scenario that's given to you, and let's say the scenario is a venous thromboembolism prophylaxis score. Like, let's say she's a 40-year-old. Let's say she's 42 years old, primary gravida, with a BMI of 45, and she has a family history of, let's say something like VTE, and she is having a renal disorder as well. So you need to score that, and you need to identify whether we need to give first of all, whether we need to give antenatal low molecular weight heparin. At what gestation do you start? Does it begin from the first trimester, or do you have to give it from 28 weeks, or she only needs the postnatal one? So all of this would depend on the score, and you would have to calculate the score on your own and pick the right answer, because they'll give you like 10 options in that. They'll give you multiple options, multiple scenarios. They'll give you TED stockings, hydration, LMWH, whatever, the dose of it. There can be multiple doses. So you need to know your guideline, this guideline well. At least venous thromboembolism is something you have to know at the back of your hand. And you will have to pick it. But in when you have like 10 options, you can't eliminate options. With single best answers, I think elimination works well, even if you're confused between two. In EMQs, if you need to know your basics well, your guidelines well, and that is when you can pick your Pick your best, pick the best option. Paper one and paper two. So paper one, paper two, we have like it's a 3 hour, 180-minute question paper, and you have a break in the middle. I think it's for an hour, and you will have an EMQ section and a single best answer section. The single best answer section might come first. It could be like my exam had, I think it had SBAs with obstetrics, then EMQs with gynecology. Then I had the break, and then I had SBAs from gynae, and then EMQs from obs. And that's how it was. So the time management would be different because it's obvious you take lesser time for single best answers and you'd require more time for EMQs because even reading the question in EMQs takes longer. Um, I hope I was able to introduce the concept of EMQs, but as you start your preparation, you'll understand what EMQs are and you will be able to conquer them better. Please don't be scared of EMQs. I think one of the mistakes that I made when I was preparing was that I was petrified of EMQs and I started practicing them pretty later on in my preparation. And I felt I did not score well because of that reason, because I was trying to procrastinate solving the EMQs. So just say that start solving them as soon as you can, and that will help you in building confidence. You might get all of them wrong to begin with, but that's completely okay because you can go back, look at the guideline, learn actively, and then you will solve them again at some point and you will get it right the next time. Okay. Um, I hope everyone's following through. I'm sorry if I'm going a bit fast. Please just tell me if I'm going a bit fast and if you're not understanding anything. We will be taking questions at the end, and but if you'll have any urgent questions, you can just put it in the chat box and I'll deal with it when we come to the end. Okay, I hope that's okay. Just give me a quick thumbs up, guys, if you all are following and you all can hear me clearly and you can see all of my slides, so I know that I'm doing okay. Okay, thank you. So I think I am audible to everyone and my speed's okay. Now let's look at the modules. So as such, we don't really have modules per se which are divided per se by the curriculum. There are, but we've made it smaller so that it's easier to teach. For example, you have modules ranging from clinical skills. I'm just gonna use a pointer if just give me a minute. Yeah. You have clinical skills, teaching and appraisal and assessment, research, IT, clinical governance. This is important because research does have statistics. Ethics and legal issues, again, an important thing. Core surgical skills, post-operative care, surgical procedures, antenatal care, maternal medicine, management of labor and delivery, and postpartum problems form a major chunk of obstetrics. Gynecological problems, fertility, sexual and reproductive health, early pregnancy care, gynae-onc, and urogynecology form a chunk of the gynecology part. As I said, we have multiple resources. Uh, we have the GTGs, that's the Green Top Guidelines, NICE guidelines, TOGs. The FHRH is basically changed now. It's not the faculty, it's the College for Sexual Health, Sexual and Reproductive Health. FIGO, we all know about this because FIGO gives us mainly the onco guidelines. Colposcopy services, consent advices. Strategy is something that's actually from the older ones because we don't have strategy anymore. We have e-learning from MRCOG. Escher and Embrace. Escher is the European Society, and Embrace is basically they look at the maternal and neonatal. I'm sorry, maternal and neonatal morbidity and mortality reports. I think what is important is that how and what we offer with is that we have sessions where you can listen to. You listen to them and you know what's important. You read the relevant guidelines, you make notes, you solve the questions, and then you revise. Solving questions is an integral part because when you solve questions, listen to this now. This listening is a passive form of learning. Reading, maybe some form is active, making notes is active, but the most active form of learning is solving questions. Because when you know you go wrong in a question, you have to go back, open the guideline or the talk or whichever it's relevant to, and you have to read it again and revise. And this is how you remember what you've gone wrong. And then the next time you do it, you're not gonna go wrong. Always take small steps. When you begin your preparation, you're not going to be solving like 100 questions in a day. That's not possible because maybe you don't know how to do them. But you can start with 5 or you can start with 10, and that is what is important. When I gave my part 2, I was working. I was working in a hospital, and we used to have our duties, and I was on a 9 to 5. I had 24-hour duties, but I used to always take my study material with me, and whenever I had free time, I used to just go through that. Even if for the whole day I just did 5 questions, but I at least did them. Correct. So there was a continuity in reading and learning, and that is why I feel the small steps is what is important. That you continue reading irrespective whether, like, you can do 20 or you can do 100. That's okay, but keep on doing. Even if it's 2, just do it every day. I've already gone over this. We know what the topics are, but what is important is that it's also important to have you go through recalls. Now, there's a major difference between this exam and part one. Is that part one heavily does depend on recalls. This does depend on recalls as well, but recalls will tell you about the important guidelines. Very rarely, I wouldn't say very rarely, the questions are repeated, like exact repeated. Mostly the guidelines would stay the same, but some different part of that guideline would be asked in the exam. For example, chickenpox or VT, you're always going to have questions from the thromboembolism guideline. So that's something that you cannot not do. You will have to do that guideline. Or for example, you will have questions for cancer screening. Okay, or you'll have questions on subfertility or labor. These are definite questions that would come, and you would have to read that guideline. But I cannot tell you that, okay, this question is going to come in this guideline, in this exam, but I can definitely tell you this guideline will be asked in this exam, because those are so important to their practice here that they need to know, that their trainees or their doctors have to know those guidelines. Okay, it's as easy as that. Which is the most important one, you have to read them. Some of them which are a bit, let's say some talks, if you're not able to do, that's okay, because again, talks are so many, it's difficult as to what would be asked. Another thing is that whichever guidelines are updated, they have to be read, because there's a chance that they would ask something out of that, because it's an updated guideline. um this is what we are offering from our end. Obviously, I'm not going too much into the detail because I don't know the nitty-gritty details of this, but our backend team is here, and you can definitely get in touch with them, and they will help you sort this out. This is just a way, or you can say a day-to-day module breakdown as to, we're just suggesting how you can study. Again, it can be tailored as per your own need, but on a Thursday, the session recording will be available on the website. You can listen to the session recording. We have given recordings. Why? Because first thing is that live lectures do help. I understand that, but recordings give you a power of, let's say, your own ability to just listen when you have the time to do it. If I'm supposed to be taking a session now and you're working, you will miss the session. You will have to anyway listen to the recording, and it's different. If you have a question if you have a question related to the recording, a doubt, you can definitely get in touch and we will be solving that doubt. So I feel recordings have that edge over live sessions. Obviously, l- we might have one-off live sessions wherein we will be updating about some talk, about some guidelines, but mainly it's heavily the sessions that are there. Then we have the green top guideline and EMQ practice sessions on Friday. Similarly on Saturday. Sunday is a self-study day, it's a break, it's a holiday. Monday, Tuesday is again the same study session, and then Wednesday is the mock on website. Now, why are mocks important is that they put you in a habit of solving like an exam. If you do it from the beginning, you will be less scared of the questions when you actually give your exam. The more you acclimatize yourself to the questions, the easier it is for you to solve on the exam day. I hope that makes sense, guys. Because if you keep it till the end, the pressure builds up, and you tend to become more stressed out. You might get all of the questions wrong. That's completely okay. Do not get disheartened by that, because you're just beginning. Okay. And I think what happens with us is that even with seniors who've been in this field for a long time is that we have our own way of practicing obstetrics and gynecology. Everyone has their own, own things that they do based on their experience. Obviously we follow guidelines, but all or guidances. So they're basically guidances. They're not mandatory things. They're guidances, but here in this country they do follow it more to the T than we do in the rest of the world. And that is why we need to know how things are done here. The answer for a particular question could be completely, for example, in PPH they have a particular way they give the drugs. In another country we might give it in some another way, we might give some other dose of the drug. So that is why we need to learn their way of doing it, and we need to solve the questions and in their way. Okay. And it's not different, the knowledge is the same, it's just tweaked a little bit as to what their guidance and what their evidence suggests. Okay. Now, for example, this is what infection in pregnancy mini schedule is basically when one module is divided or let's say subdivided into smaller topics. So it's easier for you to read. For example, on the 6th, you can start with the bacterial sepsis after delivery. That's an updated guideline as well. The HIV guideline, chickenpox, then tuberculosis in pregnancy, early onset GBS. Early onset GBS is a very important guideline again because they do uh, they do test, and obviously it's not routine testing of GPS, but they do test high risk women and they do give intrapartum antibiotic prophylaxis. Again, here is a Sunday, it's a self study day. You practice, and then in the end, you can have the mock uh, on the website. I think one thing is important is that to make some form of notes. Okay, be it handwritten or if you want to Xerox something, like if you want to photocopy something and just print it out and write on it, that's completely fine. You want to do it on your iPad or on your tab, that's completely okay. But have notes, because it's impossible to, or even if you're doing, like if you have a printout of your green top guideline, you need to make notes in those columns because that is how you can revise it. There has to be, and that's completely your thing. We cannot tell you you need to do it this way or you need to do it that way. It's how you've always been studying, and you need to use the same strategy here as well. Don't get overwhelmed by deep knowledge. That means that obviously you need to know what you're doing. You can't just have a superficial understanding, but sometimes you can spiral into knowing as to what is happening there. So sometimes you just need to, not spiral into going into what's really happening, but know what's relevant for us and the exam as well. Always follow so there are stepwise protocols here, and EMQs, they mainly test that as well. So for example, shoulder dystocia protocol, the um, or let's say the PPH protocol or the APH protocol. You need to know about how they do it here. Uh, so I think SBAs for part one, we really stressed upon the numbers and the percentages. Here also it's relevant, but there will be some questions coming in from that, but let's not fixate on it. Okay. Uh, Another thing is that our main aim has to be in solving questions and not the score. How much am I scoring, or am I scoring an 80%, am I scoring a 90%? More than that, it's like do your questions, see if you're getting them right. If you're not getting them right, just see why you're not getting them right, go back and revise. Mm, so this is, for example, a chickenpox guideline. Now, every guideline. Now, first of all, there have been changes and how the guidelines look. When you look at the older ones, you'll see they're actually the green top. They have a green top on the uh, top of the thing here. But now most guidelines do come in the BJOG. That's the British Journal of Obstetrics and Gynecology. They look a little different, and they're more gray and white now instead of green and white. That's one difference. And they have tables in the middle, and they have those recommendations. Always at the beginning they'll have like an executive summary of recommendations that still is there, but you can read only that first just to know what is happening in the guideline. But you have to go a little bit below as well, because sometimes they do ask you a couple of questions um from the, what do you say, from the part in the middle. Now, how are these guidelines made? These guidelines are basically made from, they are basically uh, uh they're an amalgamation basically of all the evidences that are available on this particular topic. It can be either RCT, systematic reviews and meta-analysis, some observational studies, and below these points, when you read the guideline, they will tell you this study told you this study told you that. Most of the times they're not going to question you on which study told you what, because they're numbers, they're odds ratios. Our mind gets boggled by all of that. We don't need to know that. We need to know what is the recommendation. Okay, these are the recommendations. In the guideline below, they give you the reasons or the understanding for that recommendation. Okay, so mainly we need to know the bold points. When you have time, when you start reading it, you'll understand it slows you down. Reading the whole thing does slow you down, but first read this, understand this, and then just skim through what's given down. Okay, level of evidence again is it is important. It gives you it will help you understanding it. But again, nobody's going to ask you if this recommendation is what is the level of evidence for this recommendation. It doesn't work that way. They just give it for the completeness, as to know if they have meta-analysis, or if they are, what do you say, if they are they have just an observational studies, or it's just a good practice point that they're putting forth. Again, practicing is important. You have to practice. SBAs can help in scoring, because that's where you need to know your stuff and need to answer properly. But EMQs are actually somewhere where you can go wrong. But if you practice, they will also help you score. Uh, so TOGs are basically where it's basically a review article. It's not exactly a guideline, but then there are some topics which don't have guidelines, and then they go as your talk articles, and they're pretty good to read because they are relevant. uh how to utilize the resources. Now, I think on the website we have I think, what do you say, the column on the left will give you the live session recordings, which will depend. For example, there'll be infection and pregnancy part 1, part 2, early pregnancy care, gynae problems, and we've divided on that. And then there'll be sessions in the lecture sessions in the particular module. And also you have the guidelines in the drive that they've provided you with. For example, the guidelines pertaining to antenatal care will be given in a particular folder. Also, you have summarized lecture guidelines. For example, we have the printed outs, like the PDFs as well, and you can actually go through them and revise with them as well. I've already gone over this, so I'm not gonna go over this again. We have different modules that we will be covering. What is important is it's a vast curriculum. Okay, you have to break down it into manageable sections. You have to remember which are the high yield guidelines. Encourage consistent revision of topics, and group discussions and case based learning is also important. That is why the Telegram or the WhatsApp discussions will help you understand, because if you there might be someone else who has a doubt which you might not have even thought about, but you learn from the other person's doubt as well. We're here to help you out. We're here for the guidance and motivation, and helping in stress management as well. If you feel overwhelmed, our team can definitely help you and talk to you. Mock exams and assessments are important, because it just prepares you better for the day. It makes your mind more, what do you say, it just keeps you it mm, you're more I'm just say used to solving the questions if you do your mock exams from the beginning. Again, we will have a premium study group which will give you the mini schedule, and they will have a daily practice of EMQs and SPAs with the moderator on the premium Telegram group. Someone asked me a question as to what books do you recommend. These are the various books, and I think they're available on our I think they're available on our what do you say, on the drive as well, if I'm not wrong. Motivation and staying focused, as I've already said this, it's a long term goal, but you have to take baby steps and celebrate the small wins. Stay connected with the team and with your peers because they help you study as well. And I just like to say that always believe in yourself. It might happen in the first go, it might not happen in the first go. Don't feel disheartened. Keep your head in the game and just focus on what you need to achieve. um I'm going to leave this on for a couple of minutes. I'm just going to take a 2 minute break and then we will be talking about the SGA guideline a bit as to what is, I think SGA, FGR is an important guideline because I think all of us as obstetricians deal with it on daily basis. And we'll have fun talking about the guideline a bit and how to how they do the whole risk stratification and scanning in this country. Uh, I'll talk about the EMQ as well. I'm just leaving you here for a minute and then we'll start again. Okay, so this is an example of extended matching question. How in the exam how this works is that they usually give you this stem, the question stem, and then they'll give you options below the question. And you have to read this and then come up with an answer. Let's look at it. A 60-year-old postmenopausal woman is seen in the clinic for follow-up after she has had a transvaginal ultrasound scan as a part of the investigation for vague lower abdominal pain. The scan shows a left unilocular simple ovarian cyst of 45 into 35 into 50 millimeters. She's otherwise asymptomatic. So here, what are we going to do? What is the best thing that you can do for her?
CA 125.
Yeah, okay. What else can you all think? We'll discuss the answer obviously, but y'all can put it in the chat box so you know I know what y'all are thinking. It's okay if y'all go wrong. We're just beginning.
Mayer CA 125.
Okay, that's option I think. Yeah. Okay. Okay, so y'all are correct with that. Let's look at the answer. I think we have the answers. Yeah, so the first one is measure CA 125. So that is how basically an extended matching question is. You need to know because all of them can be correct. You can do a MRI, you can do a full physical examination of the woman, you can do you can measure all of them actually. See, you measure CA 125, CA 99, alpha fetoprotein, beta HCG, and LDH. We do measure it, but it's mainly for the reproductive age group women. You can do a TA, you can do a TVS. All of these are not wrong. but not all of them are correct. So that is why the most correct answer here is to measure the CA 125. Are you all understanding what I'm trying to tell you all? None of this is wrong as per how you can manage a woman. You can manage it. Some hospitals might do an MRI, some might do a lab. It depends. Uh, but the according to the guideline, if you have a woman who's postmenopausal who has a simple cyst, again there's an update in this guideline. Previously there was just if it's 1 centimeter and above cyst, we would do the CA 125 in a postmenopausal woman, but that's been updated now. I think it's become 3 or 5. I don't exactly remember it. But as per the old guideline, if you have this, you would do the CA 125. Okay. Any questions, guys, so far? Yeah, it's 3 centimeters. Yeah. So I had I just gone through it. I hadn't read the whole thing. Okay. So let's move on to the small for gestation age guideline fetal growth restriction. This is, I think there's a small amendment in this guideline, if I'm not wrong. Even I don't remember. But let's look at it. Let's look at the main gist of it stays the same. Now, can you all tell me what's the difference? Just type this in the chat box, please, if possible. Is SGA and FGR the same thing, or are they different? Okay. So, what is SGA and what is FGR? Okay, Doppler changes in FGR, correct. That's 1 point. What's the other? Estimated fetal weight less than how much would be considered FGR? It's okay, fill it wrong, guys. Yes, that's correct. And FGR would be less than the third. Correct. That's right. Great, you'll know the basics. So let's start. Appropriate for gestational ages between the 10th and the 90th centile. Small is less than the 10th centile. Fetal growth restriction is estimated fetal weight or AC, that is abdominal circumference, less than third centile, or 10th centile, less than 10th centile with Doppler changes. Low birth weight is again an archaic term which is not often used, but it basically means that the birth weight is less than 2.5 kgs or 2,500 grams. Again, we don't use LBWs on scans anymore. The difference between early and late onset is basically the timing. It's less than 30 second, it's less than 32 weeks for early onset and greater than equal to 32 weeks for late onset FGR. Is the same if AC or estimated fetal weight less than third centile, or there's a umbilical artery absent in diastolic flow. Here AC or EFW less than third centile, or you have any of these. That means less than 10th centile plus uterine artery PI greater than 95th centile and umbilical artery PI greater than 95th centile. And for late FGR, any two of out of three AC EFW less than 10th, or ACEFW fall, that means the fall in the growth velocity is more than 2 centiles or 2 quartiles, sorry, and the cerebroplacental ratio is less than the fifth centile, or umbilical artery PI is more than the 95th centile. FGR, late onset FGR is more common compared to early onset FGR, but early onset FGR is usually severe. There's either going to be a very, very severe uteroplacental insufficiency, or there's going to be some abnormality, either chromosomal abnormality or some congenital malformation can also be there. What is important is that we have to, do you think women who have a previous FGR or previous SGA are at an increased risk of it repeating in their current pregnancy? What do you think, guys? A yes or a no, please?
Yes, it can be repeated.
Yes, so they are always at a higher risk of having. the in it having FGR or SGA in the subsequent pregnancies. So we need to, when they come to you for booking, you need to have this risk assessment in place. You need to know if the birth weight of the previous baby was less than the third centile. Here you need to know if there's early onset preeclampsia or FGR necessitating a birth before 34 weeks. That means the uteroplacental insufficiency was so much that she had an induced birth before 34 weeks for, because because there were Doppler changes, because there was an issue with the growth of the baby. Birth weight below 10th centile with evidence of placental dysfunction. This is the same thing. I'm not repeating it because we know what are the criteria for the current pregnancy. We know the abbreviations. AC is abdominal. I think I'm not going to go over this. Just PI. Remember, it's pulsatility index. We don't do the RI. We look at the PI, and that's something that's calculated by a machine for you. UA is umbilical. Please remember this difference. UA is umbilical artery. UTA is uterine artery, because they will be used in the guideline throughout. What's a static growth and what's a suboptimal growth? A suboptimal growth is that a previously well-grown fetus that is less than 10 centile, sorry, greater than or equal to 10 centile, fails to maintain adequate growth during pregnancy. Uh, the other thing is static growth. Static growth means that there is no growth velocity, no forward growth velocity in estimated fetal weight or AC measured at least 14 days apart. So when you scan the baby 14 days apart, it's either, if it falls, that means there's a reduced growth velocity. But if it stays the same, there is no growth, it's the same measurements almost, then that's static growth in either EFW or AC. Now, early onset FGR and late onset FGR. As I said, late is common, but why it happens is what we need to understand. Let's look at early onset FGR. Now, here, as I said, there is significant problem in the placenta that there's increased hypoxia, which causes cardiovascular adaptation. Early onset FGR has more adverse perinatal morbidity and mortality. There usually is a placental dysfunction or a background risk, like, for example, maternal issues like hypertensive disorders. It's easier to detect through screening pathways. Late onset FGR is milder deficit in the placentation, lower risk of adverse events. It's more common overall, but it is difficult to identify on ultrasound because it could be SGA, it could be FGR. You don't know. It's on a later stage that they diagnose this. Accounts for a significant proportion of adverse outcomes owing to the volume of cases. Non-placental causes of small fetuses can be, like, if there is no problem with the placenta, the other causes could be structural or chromosomal anomalies, inborn errors of metabolism, fetal infections like torch infections, maternal factors like low pregnancy weight, undernutrition, substance misuse, smoking in this pregnancy, severe anemia, and medical conditions like preeclampsia, autoimmune disease, thrombophilias, renal disease, diabetes, cardiac hypertension affect placental transfer. For risk assessment, now risk assessment here in the country is usually they have like a checklist where they use for risk assessment, and at booking and at subsequent visits, FGR risk is calculated for the woman on her notes. Um, The birth weight, gestation, and birth weight centiles of all previous pregnancies should be recorded at the booking appointment. It should at least be done by 14 weeks, the risk assessment, to identify if this woman is at risk of FGR or not. Why is this important? Why do we need to understand whether a woman is at a risk for FGR, guys? Will we change our monitoring if a woman is at a risk of FGR? Obviously, we would have more scans in a woman who would be at a higher risk. Someone who's low risk or low dependency, as they say it here, we wouldn't want to scan her that often, because just scanning in the third trimester, just measuring the ACFW is not going to change our FGR outcomes. Okay. Now, previous what we need to look at is important in our history as well. We have a previous FGR or SGA newborn, previous stillbirth, previous preterm birth, especially between 20 to 27 plus 6 weeks, recurrent miscarriages, previous placental mediated complications. In women with who have a previous FGR, we and if there's a different scoring for the aspirin as well. Aspirin can be given for both for preventing preeclampsia but for FGR also. And if there's an FGR risk, we do start aspirin 150 milligrams by 12 weeks. Previous pregnancy, again, we have a previous stillbirth, previous preterm birth less than 37 weeks, previous second trimester loss, recurrent miscarriage in second trimester. Remember this, that a second trimester termination of pregnancy is not a risk factor for SGA. Previous second trimester loss can sometimes have a placental dysfunction, but again you need to understand why the second trimester loss has happened or not. Previous placental mediated complications like hypertensive disorders, abruption, previous FGR have a risk of recurrence in each pregnancy, like in subsequent pregnancies. Where stillbirth in the previous pregnancy was associated with FGR, preeclampsia, or some placental dysfunction, additional screening is warranted in the subsequent pregnancies. Sometimes congenital uterine anomalies are associated with increased risk. Greatest risk, this is important, is with septate or bicornuate uterus. Uterine artery Doppler interpretation is also more challenging in these women. Why? Because it could be at you know you if you know how to if you try to find the uterine artery Doppler, sometimes it can be difficult. The interpretation can be difficult. Because it's not a normal anatomy, it can have its own implications. It's always reasonable to offer growth scans from 28 plus 0 weeks for women who have a congenital uterine anomaly. And remember, it's septate and bicorporeal, or you could say bicornuate, basically. Yeah. In women who, and it's good to give them scans from 28 weeks. Socioeconomic inequality, yes. Asian, African, Black African, Caribbean ethnicities are at increased risk of SGA. Why? Because they have deprivation, healthcare access is limited, and their BMIs can either be too low or high. Um, Smoking is also there, which affects your social factor that affects the FGR. Mm. Medical conditions, obviously, diabetes tends to make the baby LGA. Okay, but diabetes with some microvascular disease, sorry, will go more towards FGR. Renal impairment, CKDs, antiphospholipid syndromes, it's a known complication, FGR. Chronic hypertension, SLE, complex congenital heart disease, or ventricular dysfunction in the mother. Weaker, not significant if control is asthma, anemia, inflammatory bowel disease, depression. All show less than 50% increase in risk on meta-analysis and are not considered important risk factors. But we do, for inflammatory bowel disease, I think for inflammatory bowel disease is basically your Crohn's or ulcerative colitis, but I think we do offer them growth scans. And there is a talk on inflammatory bowel disease in pregnancy. Advanced maternal age, yes, it increases your risk for SGA, FGR. Pre-pregnancy BMI less than 18 and low gestational weight gain. Bariatric surgery, yes, will increase your risk of FGR. So you do add the screening. And ethnicity is also one of the high risk factors. Smoking, alcohol, drug misuse, yes, they increase. Caffeine in third trimester, again, I wouldn't say exactly, but yeah, caffeine more than 300 milligram per day is associated. IVF, ICSI, yes. Paternal factors, changing paternity can affect, like for example, different partners. Um, if your first baby was with someone else and the second one is with someone else, the first one could not be SG or FGR, but the second one could be SG FGR, and that is because of the paternal factors. E-cigarettes, yes. A lot of women who smoke tend to change over to e-cigarettes in pregnancy because it's they think it's safer. There is a complex relation. Women who stop tobacco and use e-cigarettes risk returns towards background. That means when on stopping the cigarettes. Continued e-cigarette use in prior smokers does increase SGA risk versus non-users in one last study, but switching fully from cigarettes to e-cigarettes lowers risk versus continued smoking. So what they're basically trying to tell you in this is that if it's the woman smoking and if the woman moves on to e-cigarettes, obviously by common sense her risk would lower. But if the woman has continuous e-cigarette use throughout her pregnancy and no cigarette, like if she's not a user, then obviously the e-cigarette one would have a higher risk of HGA. I think that just makes it's common sense that we would have such a risk factor. Nicotine replacement therapy. Uh, Harmful effects of smoking are not related to nicotine. Risk from NRT much lower than smoking, obviously. So they do carbon monoxide testing here for women who do smoke. And women using e-cigarettes or nicotine replacement therapy with a carbon monoxide of more than 4 ppm should be offered scan assessment on the moderate risk pathway for smokers. Now, this risk factor, this pathway that is moderate and high, will be e-cigarettes are basically vapes, electronic cigarettes or vapes that they use very commonly. Do we need to remember the levels for all? What levels? Uh, for the carbon monoxide? I'm not sure. Chris, please could you elaborate? I'm really sorry. Alcohol, yes, it has a dose response relation with SGA. Obviously, we recommend no alcohol in pregnancy, no smoking in pregnancy. But for women, it can be sometimes difficult to do that, and thus we have light consumption of 32 grams per week. But abstinence is obviously advised. No, you don't need to remember those. Not for your recommendations. No, no. That's what I told you in the beginning. You don't need to remember that. It's just for your understanding. And as a part, when you write a guideline, you need to give the people who are reading the level of the evidence, but they're not going to change it. Like, for example, if there's a level 1 plus, or if there's just a GPP, that's a good practice point. Your 1 plus would have be at a higher level than your good practice point, right? So that's just the way they write the guideline. But in the exam, nobody's going to ask you what level of evidence is this. Low PAPA, less than fifth centile. It's associated with SGA. Raised AFP, yes. Raised inhibin A, and raised beta HCG is not. So this raised beta HCG is not reliable association in isolation. Raised beta HCG can be there for a lot of things. I think even in trisomies we have raised beta HCG, raised inhibin A, and lower PAPA. Raised alpha fetoprotein. If I'm not wrong, is it an open neural tube defects? But I think yeah. I don't remember. But yeah, it can, PAPE is one thing that can be, and in our risk factor pathway, there is PAPE in it as well. When low PAPA, raised alpha fetoprotein and or raised inhibin A are accidentally detected on aneuploidy screen, offer additional ultrasound surveillance for SGA, FGR. That means that the baby does not have aneuploidies but can be at a higher risk for SGA or FGR. Women with low PAPA or raised beta HCG should be offered aspirin as a placental biomarker even without direct trial evidence for this indication. So it's a good practice point. What women with low PAPA or raised beta HCG can be offered aspirin, 150 milligram per day. Um, So what I'm gonna do now is I just want to take you all to the what do you guys are? I want to take you all to this because this is what you all need to understand. When we have, let's say, we have a risk assessment that's going on, we have a screening in early pregnancy and then the pathway for the FGR. Okay, let's go over this complicated diagram one by one. If a woman is low risk, that she has no risk factors, a normally scan is done at around 18 plus 6, 18 to 20 plus 6 weeks. A normally scan and in that everything is normal. Estimated fetal weight is greater than 10th centile. Here she can go for the low dependency measure surveillance. Here where you do the measurement of symphysiofundal height. If the measurement of symphysiofundal height remains normal, then it's completely okay. You reassess at 28 weeks and after, or if there is any change in the symphysiofundal height, assess for complications that are ongoing. For example, a woman who was low dependency first would suddenly have hypertension, develops her FSH, sorry, her symphysiofundal height is lower. She would be having her pathway would change and then she would go to another pathway. Now, if let's look at the moderate risks. What are the moderate risks? We have obstetric history, we have current risk factors. In obstetric history, previous SGA, previous stillbirth, but the birth weight was AGA. That means there was a stillbirth, but the birth weight was not, like the baby was not small for gestational age. Baby was appropriate for gestational age. So this would be moderate risk factor. Now in current risk factor, current smoker, that means any number of cigarettes, because I think, yeah, um drug misuse, women over the age of 40 at booking, BMI less than 18.5, and other eating disorders or bowel disorders, gastric bypass surgery, previous preterm birth, second trimester miscarriage, placenta mediated. Assess for history of placental dysfunction and consider prescribing aspirin. Like, for example, if any of the stillbirth was because of placental dysfunction, previous preterm birth was because of placental dysfunction, you prescribe aspirin. All women on the moderate risk factor pathway require a one-off symphysis fundal height measurement at 28 to 40 weeks. 28 out of 40 weeks, that means 28 weeks. Anomaly scan and estimated fetal weight is greater than 10 centile. Because she has moderate risk factor, she would get serial USGs from 32 weeks every 4 weeks until delivery. This for moderate risk factors. Now we have high risk factors. In high risk factors, you have maternal medical conditions like chronic kidney disease, hypertension, autoimmune disease, SLE, APLA, complex cardiac disease, obstetric history, previous FGR. Remember here it was previous SGA. That's the difference. This is previous SGA is a moderate risk factor. Previous FGR is a high risk factor. Previous stillbirth, which was a SGA baby. This was, if you remember, moderate was previous stillbirth but AGA baby. Hypertensive disorder in previous pregnancy, previous SGA stillbirth. Then current pregnancy, low PAPA, raised inhibin A, raised alpha fetoprotein, echogenic bowel, significant bleeding in the previous pregnancy, in this pregnancy, estimated fetal weight less than 10 centile, single umbilical artery. Single umbilical artery also increases your risk of FGR. Consider prescribing aspirin 150 milligram from 16 weeks as appropriate. For example, previous hypertensive disorder, previous FGR. Why? Because these are all examples of placental dysfunction. Then you do, and so usually at anomaly scan, we do a uterine artery Doppler. Correct. Here they're not doing an uterine artery. Obviously, most anomaly scans do it. Here you do an uterine artery Doppler, and you see that if the uterine artery Doppler is normal, estimated fetal weight is less than 10 is greater than 10 centile. You do scans from 32 weeks, every 2 to 4 weeks. Normal uterine artery Doppler, but estimated fetal weight less than 10 centile, you begin scanning earlier from 26 to 28 weeks. The again, if a uterine artery Doppler is not normal and estimated fetal weight is greater than 10 centile, you do from 28 weeks every 2 to 4 weeks. Abnormal uterine artery Doppler, AC, or estimated fetal weight less than 10 centile, this has to be referred to fetal medicine because this is early onset FGR, if you remember. Women who are unsuitable for now, what happens is women who have very high BMIs, that is more than 35, and if they have fibroids, they become unsuitable for evaluation on the by some fundal height. That is why you have to do serial USGs from 32 weeks in women with congenital uterine anomalies and 28 weeks, sorry, and 32 weeks in women unsuitable for fundal height measurement every 4 weeks until delivery. I know it's a very complicated diagram. I think if you just print it out and stick it on your wall and look at it, you'll be able to remember. It's easy. It's easy that way because it is common sense. We know we do it in our practice. We start screening at 28 weeks. Sometimes they've just told us when we need to screen for 32 weeks, when we need to start screening from 28 weeks. Management of fetal growth restriction. This is when they'd want us to deliver. Let's look at this important part again. We have early onset FGR up to 32 weeks. Now let's look if any of them have absent or reduced reversal of end-diastolic flow in the umbilical artery. You have to have minimum twice weekly CCTGs. CCTGs, computerized CTGs, and or ductus venosus flow. On CCTGs, there's something called a short-term variation. Short-term variation is It's not like a normal variability uh, on the CTG. This is a part of the Dawes-Redman criteria, and in that there is a short-term variation that you need to see. It's calculated by the machine. It's not something that our eye can pick up. But this STV tells us whether the baby is at a high risk of hypoxia or not. If the baby is from 24 to 25 plus 6 weeks has abnormal Dopplers, this has to be individualized care. Deliver by 32 weeks. Now, this is something actually the fetal medicine unit would be involved in understanding and dealing with. 26 to 28 plus 6 weeks. If if STV is less than 2.6 milliseconds and or absent A wave, you would deliver by 32 to 34 weeks. If that's it, again a decision based on the fetal medicine opinion. 29 to 31 plus 6 weeks if the STV is less than 3 milliseconds. Now here you just have to remember the STVs for this and when you would want to deliver. If FGR is between 32 to 36 plus 6 weeks, if it is 32 to 33 plus 6 weeks and abnormal Dopplers, you do CCTG twice weekly, and ductus venosus flow. If ductus venosus flow A wave is absent and STV is less than 3.5 you milliseconds, you would consider delivering. If it's between 34 to 36 plus 6, umbilical artery Doppler PI greater than 95th centile, monitor minimum twice weekly CCTG, and deliver if STV is less than 4.5 milliseconds or AEDF, that's absent end diastolic flow. Between term, now term is late onset basically, so 37 to 38 plus 6 weeks. Deliver if the AC is less than third centile by 37 plus 6 weeks. And if for SGA, we usually deliver by 39 plus 6 weeks. For FGR, we would want to deliver by 37 plus 6 weeks. Deliver if there are spontaneous repeated decelerations on CCTG, maternal indications STV less than 4.5 and absent or reversed, and diastolic flow in the umbilical artery. This is just a management of how you would do if there are abnormalities. If we most of us know all of this, okay, the only additional part that they've put is the STV, and that's something you'll have to remember. Remember STV of less STV as you go low, it's going lower, it increases your abnormality risk. Less than 4 is actually considered above 4 is okay, less than 3 is abnormal, less than 2 is highly abnormal. That's how I remember it. But it's for this guideline you need to remember that there are gestational ages that you need to remember the particular STVs for. uh you can give antenatal corticosteroids. You need to follow the steroid guideline for this. Every hospital also has their own guideline, but yeah, the national guideline is the one that's given by NICE. Um, you can give neuroprotection with magnesium sulfate for offer from 24 to 29 plus 6, consider up to 33 plus 6 weeks. Mm. How do you deliver it? Mode of birth, FGR, fetus with CCTG, STV abnormal, ductus venosus flow, absent A wave, or absent or reversed umbilical artery and diastolic flow, cesarean birth is recommended. These babies tend to not tolerate induction very well. SGA, late FGR fetuses with no uterine, with normal umbilical artery or abnormal PI, but the end diastolic velocities are normal. Induction of labor can be offered, but you have to tell them that there is always an increased risk of needing an emergency cesarean birth. And obviously, continuous fetal heart rate monitoring with a CTG is required for these babies. Uh, if there is placental abnormality, you can send histopathology. Also, there are different triggers for sending that. Women who have had growth restricted infants should be offered postnatal counseling and review of placental histology and consideration of investigations for underlying causes, example, acquired thrombophilias. A plan for future pregnancies and preventative strategies like smoking, aspirin should be in place. Because if a woman has had a stillbirth, which is associated with placental insufficiency, that has to be investigated. That has to be there has to be a postnatal conversation about this for the next pregnancy as well, and a plan has to be put in for the next pregnancy. So this is, I'm just gonna leave you all with this. It's just one of the parts of the guideline. Now, this guideline is a bit complex. I know you all must have gotten a bit confused with all the numbers and everything, but once you read it step by step, you already know half of it because you're already practicing half of it. It's just some additional points that you need to incorporate. So we're, I think, at the end of our session now, guys. If you all have any questions, is I'll just have a look at the questions that you all have put up. Do we need to remember levels? No, we don't need to. E-cigarettes has been asked for. Yes. So if you all have any more questions, guys, just please put it in the chat box. And if you all have any questions regarding the course and the payment and all of that, I'm not the right person. You can ask the backend team, and they'll definitely help you out with that. So any questions, guys, before I take your leave? I hope you all understood a little bit. Yeah, the backend team will do that. They'll share the guideline. If you'll have any questions or if you'll have any doubts, you can just get in touch with us through the backend team. I might not reply to messages directly, but if you come through them, I will answer all of your doubts. We have our moderators and other mentors as well, and they'll help you out. The books someone asked, they are available on the guide on our OneDrive or Google Drive that you say. Please share Q questions. Uh, yeah, so I'm not sure Huda about the question, but yeah, I think I have been able to at least introduce you all to the concept of what this exam is and what guidelines are. As you start your journey, you will be able to understand it better. Okay. I wish you all the best. I know all of you all, when you all have it in your head to achieve it, you all will be able to do it. Just stay strong, stay motivated, and just keep on going. That's all about I want to say. And happy studying, guys, because it's just fun to learn more about the subject that we are dedicating our lives to. Okay. So all the best. Thank you for listening in today. See you all soon. Okay. Bye bye. Have a nice day.